Alright, Huntington's disease comes up a couple of times. Hopefully this kind of links them together. It would be useful to have a foundational understanding of the direct and the indirect pathways of movement beforehand. I'll also kind of be recapping them just shortly to go over the high-yield stuff for this disease. So Huntington's is a rare neurodegenerative condition, and it's inherited. There's a progression of symptoms. So initially your symptoms start off as hyperkinetic, kind of jerky movements all over your body, and it kind of affects young people, like around 35-year-olds, for example. And this is known as chorea, which is kind of known as dancing, kind of hyperkinetic movements. Eventually, over time, the disease progresses, gets worse, and leads to complete lack of movement and lack of movement control, and this is called akinesia. So those are your symptoms. We'll explain the pathophysiology in a minute, but let's talk about the genetics of the disease. So all of us have a region of DNA on the on our fourth chromosome on the P arm, the little arm, and this is called the Huntington's gene. So remember, just the gene is just a region of DNA. Now this gene codes for something called the Huntington protein. That's not so important, but you could know that. However, you need to know it's on chromosome 4. Now, let's get rid of those. So the gene has variations, and obviously those variations are known as alleles. And for Huntington's disease, this gene is passed on. The allele is dominant, meaning that males and females will kind of both be equally affected in the population. And also you should be able to draw a pedigree for this, so it's dominant, remember. Okay, what exactly is the allele for Huntington's? What is the variation? So basically within this gene, people have different, within the Huntington's gene, there's different numbers of repeating sections of DNA. So there's a repeating section of a codon, the CAG glutamate codon. So some people, for example, have 10, you might have 15, some people might have 5, for example, so that's the allele. Now that's dominant, so if I have 10, for example, and I pass on my dominant allele to my kid, they'll also have 10, for example. So that's what we're saying. Now, however, further mutations in that gene can lead to them, for example, having 15, and then they have a kid, they inherit 15, but then that might mutate a few generations later, and that kid will have maybe 20. This can go on and on and on until we get up to about 40 repeats. So that's essentially just a summary of what we've said, but this is kind of a simplified version. You'd imagine this region of DNA having CAG 40 times, and when that happens up to 40 times, essentially this can cause this Huntington protein to misfold, leading to Huntington's disease, leading to these two symptoms. So the key number you need to know is 40. When there's over 40 glutamate repeats in this region of DNA, this can cause Huntington's. And they say that having over 36 can kind of be preclinical Huntington's as well. Now, just kind of a more advanced genetic point about this. For example, say someone unfortunately has Huntington's. So say they have 40 repeats of the CAG bit in their chromosome 4. Say they have a child that child might go on to have further mutations that introduce even more CAG repeats. Essentially, that child might have, for example, 46 repeats, and their child might have 52, for example. So throughout generations, the disease can kind of get worse. There's basically more repeats, means that the disease gets worse. So this is known as something called anticipation. That's a key word. Essentially, the more repeats you have in subsequent generations, the more and more aggressive the disease gets. So over generations, the disease gets worse and worse, and affects you at a younger and younger age. So that's anticipation. All right. This is everything we mentioned. Just to summarize, let's talk about the pathophysiology. But before I talk about that, let's kind of recap just the high-yield stuff to know about the direct and the indirect pathway. This isn't all you need to know about these pathways, but if you've learned them before, this is kind of just to recap the main stuff, the main ideas. So we've got, it all starts with our striatum, which is our caudate nucleus and our putamen. And essentially, the thalamus leads to movement. However, that's normally kind of kept under a leash. The direct pathway takes that leash off and disinhibits the thalamus, leading to movement. So the direct pathway leads to movement, and the indirect pathway activates a guy called the subthalamic nucleus. And this guy, again, is like another leash to the thalamus. So the subthalamic nucleus turns off the thalamus, leading to an inhibition. Indirect pathway leads to inhibition of movement, so reduces movement. Now, dopamine comes along and can modulate these pathways. It acts on the striatum via D1 receptors to turn up the direct pathway, and it acts via T2 receptors to turn down the indirect pathway. Now, if we're turning up increased movement, we're leading to more movement. If we're turning down a reduction of movement, that's kind of hard to wrap your head around, but say something reduces movement and you turn down the thing that reduces movement, then you'll increase movement. So the really high yield thing is that, in both pathways, dopamine leads to more movement, whether it's the direct or the indirect pathway. If you put dopamine on the striatum, then your body is going to move more. With that said, let's talk about some pathophysiology. So for the first kind of symptom of the hyperkinetic side, there's two potential pathophysiologies that you need to know about, and both of these are kind of like theorized. So the first one, is hopefully simple to understand, is theorized that there's too much dopamine being released onto these pathways, leading to, and remember, dopamine leads to more movement. So if there's too much dopamine, we get excessive movement, basically leading to these irregular, jerky movements. So overstimulation of the dopamine receptors, too much movement. And this can be treated kind of logically by depleting dopamine. So if the theory is there's too much dopamine, we can deplete dopamine with a drug called tetrabenzine. Essentially, you can think of it as a dopamine antagonist. If you want to go into more detail, essentially it blocks dopamine from being packaged into vesicles by blocking a VMAT transporter. Okay, there's another thing that is thought to cause this hyperkinetic movement, essentially. So we talked about dopamine, but if you look at the pathways, which pathway do you think will be damaged to create hyperkinetic? You could either have the direct pathway being overactive, right, or the indirect pathway being underactive. So in the case of Huntington's, in the initial kind of cause of symptoms, what happens is your GABA neurons from your striatum in the indirect pathway degenerate. This is also known as the ENK pathway, but that's kind of not that important. Essentially, your indirect pathway degenerates. Those GABA neurons degenerate. Your globus pallidus external becomes more active, essentially leading to your subthalamic nucleus being less active. Remember, the subthalamic nucleus turns off the thalamus. So basically, we're turning off the thalamus less, meaning we're reducing movement less, meaning our movement is excessive. So this can explain the hyperkinetic movement. So there we go. We've got two things that can account for two kind of theories that can explain the hyperkinetic movement in Huntington's disease. Okay, then what explains that fact that akinesia later on? Well, this is thought that the direct pathway as well as the indirect has also degenerated. So now both pathways have degenerated. This can be the direct pathway fibers are known as substance P fibers, but again, that's kind of not important. Essentially, by the time we've got to our worsened disease, we've had our indirect pathway kaboomed first, and then our second one skadooshed as well. So our direct and our indirect are now gone, leading to akinesia. Let's talk about scans that you can see. So firstly, what scan is this? Is it MRI? No, it's not an MRI. It's a CT scan because you can see this big white outline of bone. Obviously, like CT is X-rays. X-rays are good for bones, right? What stuff can you see? So this is a normal brain. You can see here a caudate nucleus. So the caudate nucleus is this bit here. And then the lentiform nucleus, lentiform meaning lens-shaped. So kind of this is like a lens-shaped, like a prism kind of thing maybe. I'm not sure if you can see it. On the outside, however, we have our putamen. And on your inside, kind of darker, you have your, darker than the rest, you have something called your globus pallidus. And you can see your lentiform nucleus is this thing here. And in between here, you have your ventricles. That's your drainage system of your brain. And they're black because they contain fluid. They contain CSF. Let's talk about what you see in a patient with Huntington's disease. So straight away, that lentiform nucleus, which is part of the basal ganglia, which is part of the direct and the indirect pathways, you can't really see it. So this kind of outline, this triangle here, is gone. And this circle here of the caudate nucleus is gone as well. And instead, we've got the space being filled with the ventricles being enlarged. So we've had atrophy of our caudate nucleus and lentiform nucleus. This should say so the lentiform nucleus is our putamen plus globus pallidus. So there's a typo there. But the ventricles, to kind of make up for the atrophy, the ventricles have taken up the space and they become much bigger to kind of make up for that limited space. So we've lost space. But obviously your brain can't be empty, so to kind of compensate for that lost space, you get your ventricles swelling up massively, both at the front and at the back. So those are the things that you can see here. Basically, atrophy caudate nucleus, atrophy lentiform nucleus, and enlarged ventricles filled with CSF to compensate for this.